Hello, everybody. This is Irma Jennings and Dr. McCormick, and we're presenting today on the errors that happened with DEXA. And one of the main reasons for this is that, well, first of all, DEXAs are notorious for having errors, but when the doctor gives you, the patient, a two-page report, and then you want to have a second opinion, it's basically useless. Am I correct, Dr. McCormick?
Very much so, yes.
You need the full report, which is the shows the images. Color is great, not necessary, but you need the full report of the hips and the spine. And we're going to talk about why that's important as far as evaluating the bones. So let me tell you a little bit about Dr. McCormick. He is the author of Great Bones and has been dealing and healing bones for all of your life? I don't know, for a very, very long time. Maybe 20 years, did you say? Yeah. Has been seeing clients privately over Zoom or in his office. Currently, he's booked out till November, so that's that with that. And the Great Bones is really making an impact as far as in the world of doctors and also lay people to really understand what could possibly be going on with their bones, especially when they say, I don't get it. I've done everything. I eat right. I exercise right. I do everything right. But yet there's that osteoporosis. So give some insight into that. And I am a bone coach and a patient advocate. So I help clients go from the diagnosis all the way to the end result. I don't want to say the end result, but walking them all the way through and working with Dr. McCormick. We have a very respectful relationship. And one of the things, we have a lot of things in common. I don't run marathons, but we both do celebrate the strength of women. And I think that that's a very, very important point because women are the dynamic aspects of our country. I think that's my opinion. Now, I'm going to tell you something. This is going to sound unusual, but I'm going to put this on YouTube. So I'm going to ask if you're seeing this on YouTube, please subscribe to my YouTube channel so more people can see this video. Like the channel, make a comment. That would be really great. And then also share the video. That would be really extraordinary. Thank you for that. So, Vicki, why don't you go ahead and start sharing the slideshow?
Me do it in presentation mode, present. Okay.
Okay, so this is Dr. McCormick's book, which everybody should have. If you have bones, you should buy this book. That's just my recommendation. Okay, back. You can go to the next slide. I'm going to read this, Dr. McCormick, and then I'll let you chime in. The DEXA technology became or arrived on the clinical scene in 1987. And what the DEXA scan does, it emits two energy beams, one high energy and the other low energy, to differentiate between soft tissue from bone. Okay, Vic. So this is what's sort of very interesting, and why a full DEXA report matters, because there are three areas of the bone of the DEXA report that are important when somebody's looking deeply into your bones. And it's the bone mineral content, which is BMC. And this tells the amount of mineral mass in the spine and hip. The bone area, BA, and you'll see these on your reports and say, well, what are these things? But this is what they are. This is the area in square centimeters, CM2, of the bone being analyzed. And then we have the bone mineral density, which is what everybody basically refers to as the DEXA. But this is how much mineral mass in grams divided by CM2. Did I say that right, Dr. McCormick?
It's a two-dimensional picture of a three-dimensional object. That's why the CM2. That's because it's centimeters squared. It's just saying that you're only seeing this in two dimensions. There's no depth to it.
Okay.
That's what it's saying.
Thank you. All right, Vicki, go ahead and. So this is the basic parameter of understanding low bone density, and the how it works. It's very confusing because it's negative.
Whoop, sorry. Don't know why I did that.
So when you look at your DEXA, and it will have, if it has the images, and the colored images, the normal is the green area, and that's a T-score of -1.0 or above. Do you want to talk about that, Dr. McCormick? Why don't I let you take it from here? Because this can be a little confusing to everyone.
It is, because when you say negative 1.0 or above, what's that mean? Yeah, so it is hard, I think. So they're just saying that if it's a +1 or a 0 or a -1, then you're okay. That's a normal T-score. You get lower and lower and lower, -1 to -2.5. That's osteopenia, which isn't a diagnosis. It's just a condition. There is no real diagnosis of osteopenia. And then osteoporosis, anything -2.5 or less. So -2.5, -2.6, -2.7. And the other thing confusing is a person is told they have osteoporosis, or they're told they have severe osteoporosis. So what's severe osteoporosis? And that's you can have severe osteoporosis and only have a -2.5. But if they have a fracture, then that is what makes this severe or not. Which is kind of a little weird, because you can have -4.0 and it's not really sometimes called a severe osteoporosis, but anything below -3.5 is severe osteoporosis, I would say.
But the fracture trumps everything, right? A fracture.
Fracture trumps there. And why is that?
Why?
The reason why is because bone strength is a combination of bone quantity or density and bone quality. The problem with the bone density is you only get 50% of the gain. And so they're hedging their bets, and they're saying, well, if you might have a -2.5, which looks not too bad, but if you had a fracture, then you probably have poor quality. And so a severe osteoporosis. So they're just taking it a step further and looking at the quality aspect of it, when we really can't, except for TBS, which we might talk about later, trabecular bone score. But the fact that remains that a bone density only looks at density and not quality.
So Dr. McCormick mentioned the TBS, the trabecular bone score, and that's a software that goes over the DEXA that some facilities have. More and more have them. I've been hunting for TBSs for clients for a long time. And it's hard to track. And sometimes they have it, and then sometimes they decide not to renew it. We had that case with one of our.
It's only, I think, $7,000 a year. So.
So Vicky, can you mute somebody?
I don't know who they are.
So please mute if you're
Okay, just did one.
okay.
But I think it comes. You're there, Irma?
Where's Irma?
I think we lost her.
We lost Irma.
I'm here.
Oh, okay.
And so it looks like you can't maneuver the other aspects, Vicky. You can't maneuver.
Well, because I have this on my screen, so.
Yeah. Now I have to find Dr. McCormick. So, okay, bear with us, please. Thank you.
I'm here.
I know, but
He's right there.
I can't see you. I don't see you on the screen. I just want to go here and make you add the pin. Okay. Okay, we're back.
So why don't you go to the next slide, please, Vicky? If you're done, Irma.
Yes, I am.
Okay, so before we get into this, I want to reiterate what Irma said earlier about getting the full DEXA printout. And I ask patients, every single patient, to send me the printout, not the radiologist report. Because as Irma said, the radiologist report is fairly worthless. And I need the printout. And the reason why is because that printout not only has all those numbers that Irma was talking about, the bone mineral content and the grams per centimeter squared, the area, but it gives me each individual vertebra bone density. It allows me to see how the technician did the scan itself. And so many of these are wrong. And I get lots of just the radiologist report, no printout. And that's what it's called. It's a DEXA printout. That's what you need to be looking for. And I also get lots and lots and lots of ones sent to me with very poor imaging resolution of the pictures themselves. I think people don't understand that the pictures are vital for me to look at. Part of the problem is the patient, and a huge problem is the hospital. They don't, the people that the patients are asking, to have the printout, the people, behind the desk don't know what a printout is. They just think it's the radiologist report. So my sister, she said for months, she tried to get her printout and just could not do it. So I know it's a huge issue, and people try and they can't do it. So, it's not always the patient's fault. It is a big problem.
And it shouldn't be, because it's our bones. It's our bones, our body, our medical report. And it's one of these things that as women, we have to band together and say, okay, we need this. My doctor at University of Pennsylvania said, we don't do those printouts because the patients get confused. So I said, yeah, but if I want a second opinion, she's like, so I had to go up to the head of University of Pennsylvania. And say, why is this so difficult? So, I'll make those kind of phone calls, that's what I do as an advocate, but it just is wrong. And it's unfortunately, but okay, I think we made that point. So if people have the book and they want to refer to what we're talking about, this is on page 83 that we're going to be starting with the DEXA errors. Okay, Dr. McCormick, you could take it from here.
Let's talk about the first thing here, inconsistent region of interest selection. So Vicki, go to the next slide and we'll show people what a region of interest is. Well, I guess the next one, keep going. No, keep going.
Keep going.
Okay, so now,
okay.
Those lines around, can people see my arrow?
I don't. I think I'm in control of that. I'm sorry to say. I wish I had.
So those lines that go around the vertebra. So there's essentially two boxes. There's the rectangle box that goes around and shows that L1, L2, L3, L4. Those are regions of interest. But then there's another area where they actually outline the vertebra themselves, and that's done automatically by the machine. But the technician can change that if he or she wants to. But the region of interest is that major, rectangle around each vertebra. And then when we get to the hips, there's also regions of interest. There's the hip neck, there's the hip total, and there's the trochanter. But I'll show you that when we get there. But these are that's what's called a region of interest. So go back to that first, the other slide then. Great, there. Thank you. Thank you. So what happens in commonly seen errors are people will, the technician will 1 year label, say L1 as L1, and then 2 years later, they will label that L1 as L2 or, T12 or something like that, but they don't keep the region of interest consistent year after year. And okay, so that's one. The next point here, averaging errors. This is really, really common. When you, like on the vertebra, the L1, L2, L3, L4, and we're going to see some examples of this, the averaging error can occur because they include vertebrae that they shouldn't include. And so if one vertebra has a compression fracture or another vertebra has degenerative joint disease, or there's an overlying belly button ring or something like that, they shouldn't include that vertebra in the averaging of the lumbar spine. It was interesting in my book, for some reason they missed a technical box, and I go a little bit more in depth in this whole averaging error, but somehow got excluded from the book. So, but it's called an average an average weighted area, and what that is they take the bone mineral content and they divide it by the area, the grams per centimeter squared, the area of all the vertebrae that they want to include, and then they come up with a number, and then they go to a normative database and look up that number for those vertebrae, and there's an algorithm that calculates the total bone density. It's called like I said, it's the average weighted area that they call it. The problem is it's complex, and in the book I mostly just say, well, if we excluded L1, then let's just average L2, L3, and L4. And that's not exactly right. A lot of people can go to their bone density and say, oh, but I averaged L2, 3, and 4, and that didn't come up with what those averages were. So if you have 3 vertebrae like L2, L3, and 4, and they are instead, so we exclude, or let's exclude L2, and let's just average L1, L3, and L4, and let's say they're negative 3.1, negative 3.2, and negative 3.3. So the average should be negative 3.2. It might not be. The actual average might be something else. And the reason why is because an algorithm figured out that the weighted average. And so it's a little more complex. So in the book, I just kind of leave it simple and say, well, we just average those 3, and that's good enough. So, but anyhow, it gets a little complicated. So that's why I didn't really go into it too in depth in the book. But there are a lot of averaging errors that happen. So, were you going to say something?
Well, we're going to get back to why you would remove one vertebrae, and that's going to be an example that you can show later as far as a compression, and why it's important to really understand that. But that will be clearly, we have a slide on that, so that would be easier to understand. Okay.
Errors all the time. And we're going to show a really good example of a positioning error. A patient had, they had a block under their legs on one. They didn't have a block under the legs on the other. And so they positioned that patient very differently from year to year. And it really made a big difference on bone density. Really, so when you go in, so when a patient goes in there, try to remember how you were positioned. And if it seems really weird, then write it down. And then when you go back a year or 2 later, kind of look at your notes and see how they positioned you, because it is different all the time. The reason why is because there's different technicians, and different technicians do things differently.
So what I want to say about that is that Dr. McCormick was making reference to a block. So the block is where you put your legs. It's at a 90 degrees, so your spine is flat. That's the purpose of the block. The other thing is that if for a good DEXA, they rotate your feet in 15 degrees so they can get a good look at the hips. Am I correct on that?
Yeah, and a lot of times they don't rotate people's feet, and they should. And other times they over-rotate people's feet. So they really, there is a foam block that they are supposed to use that bring the feet in to the same amount on every single patient. And they should use that, but a lot of the technicians don't use it. So it shouldn't be a guessing game. Oh, I'm going to rotate you in, hold steady, patient, don't move, and then one foot flops out and the other foot doesn't, or something like that. But they really should tie a person onto this foam block with the angle just right, and then it would be consistent each time. But that's not what happens.
So I just want to interrupt for 1 second. People are making comments in the chat. I'm afraid to go into the chat because that might take away from the slideshow. So I'll go back and take a look at that after the slideshow is over. Okay. So where are we now?
Scanner improperly maintained. Budget cuts, scheduling issues, people that don't understand how these scanners need to be maintained and calibrated. A lot of them aren't calibrated properly, and if they are, then they get out of calibration over time. They need to be calibrated routinely, and that's another reason why a person's bone density can be different, and it can be wrong. And I cannot tell that. When I look at a bone density, I can't tell if that machine has been calibrated properly, when the last time it was calibrated. So there's only so much I can do when I'm looking at these to say, yeah, I think it was done properly. It looks like it was done properly, but wow, that bone density is really, really, looks wrong, but I don't know why. But so it can be calibration issues. And there's just, inherent fluctuations in bone densities, in bone density machines, whether they're electrical reasons or whatever, I'm not sure, but there are fluctuations that happen. And poorly trained technicians, they might have gone and done proper training, but they just, they fell asleep and they weren't really that interested. It was just a job or something, but, and how does the patient know whether we have a good technician here or somebody who's not, up to the proper level? You just don't know that. So there's.
It's tough to ask the technician, are you properly trained, or have you taken on Dexatec?
Yeah, get properly trained. Are you official or no? Yeah, it's hard to do that. So.
Okay, Vic.
Okay, next one. Just assurance programs, same thing. Artifacts, belly button rings. Oh, I get that quite often, to where not necessarily belly button rings, but bras. Those the wire underneath the bra. A lot of times I see that on L1, and you shouldn't. If a person has large breasts, and it's just beyond belief how many times I've seen that.
So, and I want to pause that for a second, because when I went to get my last DEXA, she said, "Oh, you don't have to change." I said, "No, I do. I have to change. Give me a gown, please." So that's something that we should make sure that we do. Take the bra off. The panties are okay, and make sure you have nothing else. And if you have any belly button ring, is what you were saying, that should be removed. I did remove my belly button ring from my DEXA. Anyway, let's keep going.
Improper determination of ROI, we just talked about that already. Vertebral compression fractures, they need to not be included in the reading. This is as I said before, this is a two-dimensional picture of a three-dimensional object. So when you take a vertebra that's been compressed, it has a compression fracture. It's the same amount of material, but in a smaller space. And remember, one of those readings that is on a bone density is the grams per centimeter squared. So you're looking at the area of that vertebra. And if that area of the vertebra is smaller, but it's the same amount of junk, it's the same amount of bone, it's going to then read as a better bone density. And so you can't include that in the reading. Vertebroplasty and kyphoplasty. They not only, on a kyphoplasty, they not only take a balloon and increase this, or try to return that vertebra to its original size, but then they inject a lot of cement in there. So in either case, whether it's a vertebroplasty or kyphoplasty, it's much more dense.
Excuse me one second, Dr. McCord. Can you please mute? Everybody mute, please.
I think Donna is not muted.
Donna, please mute yourself. Okay.
It's just going to be much more dense than it really is. And so you just need to chuck those vertebrae, just not include them in the reading. Okay. Errors in reading the DEXA. I see that all the time. It was done properly by the technician, but then the radiologist reads it wrong. Improper positioning the global hip. Okay, we're going to talk about, that's a specific one, but we'll look at that later too. Okay, next one, Vicky.
That's just a little
Showing
photo.
us.
Okay, so this is a mislabeled, so there must be a second one here. Go to the
That's-
next.
I don't know why it's not showing up.
It's not loading, Vic.
It was there earlier. Wait, let me go back. It's not loading.
Okay, go to the first one. So if you see that L1, the region of interest L1, and there's little projections off the side, those are ribs. So typically L1 doesn't have ribs. Sometimes it does, but most of the time it doesn't. That's the first vertebra in the lumbar spine, and it is the first vertebra in the spine that now loses its ribs. So the thoracic vertebra there's 12 of them. They all have ribs. Sometimes, like I said, L1 can have ribs, but most of the time it doesn't. So here you can see the ribs clearly coming off of L1. The whole thing the whole grid should have been brought down one segment. Okay, go to the.
Let's see if it shows up. I don't know why it's not showing up. I can stop sharing. You can talk for a little. I can see if I can do it.
You can go back to that first one and the second
Okay.
one. And they brought the whole grid down, so it was labeled properly. But what it did was it just became very inconsistent. And this time they took T12 and said it was L1, and it wasn't. And the next time they looked at L1 and labeled us L1, so it was proper, but this one wasn't done. So it ended up being that you were talking apples and oranges on 2 different years, which can't do that. So it's an easy thing for you, the patient, to look at that and say, okay, from year to year, I'm going to look at my region of interest from year to year. Don't rely on the radiologist. They mess it up all the time. Don't rely on the technician to get it right. You need to look at your own bone densities and see. It's a lot of these things are easy, and don't think that, oh, it's too complicated for you to do. It's not. It's very easy if you know what to look for. Okay, keep going. Yeah. Okay. So this is one thing you probably won't be able to do yourself, and that is look at, but once I teach you how to do it, you should be able to do it. So look at the T-scores on these, and you see how, negative 2.5 is way better than any of the others. So it's a little weird, right? You look at that and you go, huh. And then you go to the picture itself, and I think everybody can see that that's squatted down. It doesn't look as big as square as L2, L3, and L4. And L1 is squatted down, and it's a compression fraction. So, and then you look at the L1 and the T-score, and yep, it's a negative 2.5. It's probably a negative 2.9, negative 3.0, something like that. But it's just way different than any of the others. So
What do you do with that? When
you just can't include it in the average, and it is exactly 1 standard deviation away from the others. So it, technically speaking, it conforms to the rules. You from saying that, you can include it in the reading, and the radiologist did include it in the reading and came up with a negative 3.0. But the 2 reasons why you can't include a vertebra in the reading is, number one, if it's more than 1 standard deviation away from the other vertebra, or it's a compression fracture. So you might have a compression fracture, i.e. in this case, this is a compression fracture, but it is not more than 1. It's just exactly 1 standard deviation away from L4. So technically speaking, you'd say, well, so I can include it. No, you can't, because it's a compression fracture.
Now, if you have a compression fracture, will you know it?
No, not necessarily. 50% of the time you do because it hurts. 50% of the time you don't. So that's, a good point. So, but the radiologist reading this should have seen that. And this is an easy one to see. So
I just want to point out, we circled the model number because you want to be consistent to get the same model number, same,
yes.
same machine. So
Yeah, good, Irma, for noting that. Always look at your serial number, and that's the other reason why you need a printout. If you just have the radiologist report, you're not going to know what the serial number is from year to year. And just because you went to the same hospital in the same room and it was the same technician doesn't mean it's the same machine. They might have switched it out.
but we're actually reducing the chances of error if it's consistent, right? If you have the same machine, same serial number, at least we have the basis that
Right.
that's the same.
But there's so many of these steps along the way that you, the patient, can do. And you might not, you probably won't go in there and say, hey, technician, what's the serial number of this? No, you're not going to do that, but you are going to see it after the fact.
Right, you'll see it on the report. Okay, Vic. So what are we doing here?
This was a hard one.
Yeah.
So, I know it sounds weird, but I do. I mean, number one, my eyes are bad, so I use a magnifying glass all the time for a lot of things, but I do use a magnifying glass all the time to read bone densities. And so I look at these things really closely. And if you look at that L4, you see on that left-hand side, it's the top part of the left-hand side of L4 is dropped down a little bit. There's a little black line. Can you point that out, or Irma?
Can you see this arrow?
That black, yep, that's perfect, Irma. But that black line, and then go to the other side, go to the right side of it, and see how that black line is higher up.
Mm-hmm.
So so I looked at it and I go, oh, it's a little weird, and so yeah, it was a compression fracture and it shouldn't have been included in the score.
Yeah.
But you can see those things. Sometimes they're pretty easy. Like this one was kind of easy, but okay, go to the next one, please. So there it is. You can see how squatted down that left side is compared to the right side. And they see the line, the blue line, that should be at an angle. They did that wrong. It shouldn't touch the bottom part of L3 and not touch the bottom part of L4. Do you see that?
Mm-hmm.
Can you show me that, Irma? Okay, go to the next line. The next slide. I think, yeah. See that? See the black line that I put in? That is the way. So that green or blue line that they put in is wrong. They should have put that black line where I put that black line. That's how they should have done it.
At that angle.
That angle. They should have made that angle. You should go right through the disc, through the center of the disc. So there should be equal amount of disc above the line as below the line. So it should be the same distance away from the bottom of L3 as it is distance from the top of L4. So that line should dissect exactly that disc. So half the disc is up above and half the disc is below. But then look at those other arrows, and you can see how the left side isn't as high as the right side.
And this is not scoliosis. This is just a bad DEXA. Yeah.
But you cannot include that in the score.
Right. Did you hear me? This is not a case of scoliosis. This is a case of a bad.
Yeah, no, it's not scoliosis. I mean, go back to that two slides above, and you'll see how it's straight. Yeah, see, it's just a straight vertebra,
right?
Straight spine. So
Right, okay. All right. So now,
um, so
no,
oh, okay, these are, if it loads, these are your regions of interest in the hip. I think that's what this is.
it is, but they're not going to load.
Yeah.
Mm,
I don't know why.
But it doesn't matter. We don't know why. But can you? Is there an alternative, Vicky? Can you go not share the screen or not?
If I stop sharing the screen, no one will see it. I'm going to stop sharing. I'm just going to see what's going on.
And let me look at a couple of questions. Donna is asking, is it possible to have my recent DEXA scan reanalyzed by the tech using the same scan, but with the selections consistent with a previous scan? I had inconsistent labeling, very obvious, just as you described. Just wondered if it's possible. Otherwise, it was a waste of a scan.
It is kind of a waste of a scan, and they should just redo it again. They won't reanalyze it. They should just redo it. The technician doesn't really have control over that. So that the person asking that question, in a perfect world, they should be able to go to their medical doctor, say, "Hey, Dr. Smith, this isn't right. Can you redo the scan?"
I tried to go back to University of Pennsylvania and ask them to reanalyze. No, actually, nobody knew what I was talking about. So that was one of the challenges that I had. So Susan is asking, last 2 times at Dartmouth, the tech was calling someone to check about positioning. That can be good, but it does imply the tech was not fully up to grade.
Right. They were just probably new, and they wanted. But I mean, the good thing is they were asking for help, which was great. But yeah, they were probably new, but it's also good too. So yeah, you can look at it two ways, I guess.
That's right. That's right. So Brenda was asking, should your lumbar spine be pressed against the table or arched?
It should be flat against the table. So this is a perfect example. This is when the person was not, they didn't have their feet up on the block. And so the person's spine was really arched, and that L5 vertebra was really squatted down because they're so sway back. And so I'm a little afraid, Vicky, to ask you back to the one before, but here that L1 is L1, and then here they have L1 as L2. But also now go to the next one, Vicky. Yeah, but also here they included way too much of the sacrum, and you can see that L5 vertebra. You almost can't even see L5 because they were so sway back. Mm-hmm. So really wrong in so many ways on this.
So does the block take care of the sway back?
Yeah, it just should flatten you out. I mean, some people still have, you can't get rid of the whole thing sometimes, but most of the time, if your feet are up on that block, that should, flatten out your back.
Okay. So should we move on?
Yeah.
So there it is.
Perfect. Right. Oh, super. Thank you very much. This is great. So this is the global hip. So see the arrow in each one. You want, well, both, this is hard to say. Go to one more picture. The next, no,
we don't have another one.
Okay, I thought you had another hip. So yeah. On the left side of that shaft, you can just barely see a little bump there. And that is called your lesser trochanter. Can you show where that is, Irma?
Vicky, can you do that with your pointer?
Can you see my cursor?
Yeah, but not everybody can, though. But I'll point here. This is the trochanter that Dr. McCormick was talking about, right?
We can't see it from you either,
yeah.
Irma.
Okay.
So go. Okay, wait.
Cursor, maybe.
So that's not the trochanter. Now go to the right.
Right here,
Yeah. Now go down, down, right there.
Oh, right.
right here.
Little bitty bump. There's a teeny bump there. That's your lesser trochanter. And you should have more of a bump, number one. You can actually, on the second one down there, you
Second
can
one, this bump here.
see a little bit more bump. Yep. But the distance between the line where I have the red line, the red arrow on all the pictures. Yep, that arrow. So that line, that white line that goes across, that's the bottom part of the global hip region of interest. So that line should be the same distance from the lesser trochanter as all the others. See how there's a huge discrepancy. So now the whole global hip is very different on all three of these. And that's going to change the total hip bone density score. So
in 2019, where there's very little trochanter showing,
that's not correct. They should not have done that. But the nice thing is they essentially did the same error all three times. So that's okay. As far as rotating that hip, they under rotated the hip in every single instance, which is fine. It's not great that they did that, but at least they under rotated the person consistently. So that was good. What is not the bad thing about these three is they changed that bottom line of the global hip each time. And that's where we get a problem.
So because in 2020, the box is bigger than the 19 and 21. You know, 19 and 21 are pretty good. So the other things to look at are that little rectangle that goes around the hips. So often that rectangle overlies the greater trochanter. That's the big bump on the right-hand side. Yep, that's the greater trochanter. A lot of times that rectangle will migrate down or to the right and actually cover some of that trochanter, which it should not. It should not cover any part of that trochanter. And a lot of times I see 1 year it covers it goes over onto the trochanter, and the next year it doesn't. So that would give you completely error in the hip neck score. So if you see something like that, that's the kind of thing that you should be able to go in and say, you guys, you got to do this over again. It's not right. You got to read. And you're suggesting get a fresh DEXA?
Yeah, you can't change that because it was done. So it's a done deal once they put that region of interest in a certain place, take the density. You can't go back and without the patient and do it again. So.
Okay. So go ahead, Vic. So this is the contact information for Dr. McCormick and for myself. The purpose of this brief webinar is to show you how complicated it is and how important it is to get the full report. It would be great if it was easier, but
it is hard. But my book does point out some of the easy things to look at. And I'm not asking people to become radiologists. I'm not asking you to say, hey, you all can be responsible for the integrity, the quality of these bone densities. I'm not saying that you can do that. I'm just saying there are things that are pretty easy to see, to spot. And I did see somebody ask a question of how many of these errors can you have without it being totally worthless? And that's a great question. And you get, sometimes all it takes is one error and it's totally worthless. Other times, you can let it slide and if one hip bone density, they rotate you a little bit more or less than the other, I wouldn't worry about it. Don't worry about it. But when when you can see a lesser trochanter all the way on one, and the next year you can't see that lesser trochanter at all, that's a problem.
Okay. All right, Vic, you want to go to the last slide and then we'll take the slideshow down. So thank you for joining us. So we can end the slideshow, Vicki.
I did.
Okay, thank you.
Thank you, Vicki.
You're welcome.
I was just going to do one thing, Dr. McCormick, because when we're talking about the blocks and things like that. So let me share my screen and go to my report. So this is my DEXA that I had done a while ago, 2022 or 21. Anyway, this is the trabecular bone score that Dr. McCormick was talking about earlier that looks at the inner part of the bone. This is the L1 through L4.
I think you're bragging, Irma.
I'm not.
That is super. Oh my God. That is just great.
Thank you. And
I'm jealous.
you jealous? Okay, that's cool. I just wanted to show the positioning. Whoopsie. Okay, so this is the positioning with the block. And you want to have the block my socks are dirty, but that the hips are rotated.
Yeah, and see how our foot are against that angle? That's the way it should be. That angle is going to be now consistent every single time Irma goes and gets it done. If her feet are against that angle, it's going to be the same every time.
And this is the block.
These are great.
And this is the block that we were talking about, so that the spine is, well, we see that it was during COVID, but the spine is flat. And then I also had the forearm done. Do you want to talk about why we do the forearm, Dr. McCormick?
Well, I like forearms because a lot of my patients are going to go on Forteo or Tymlos, and forearm is 80 to 100% cortical bone, and so cortical bone is destroyed pretty commonly by parathormone from the parathyroid glands, and so you'll see a person with really, really low forearm bone density a lot of times when they have a parathyroid involvement. That's one reason. But the other reason why is because if we're going to put a person on Forteo or Tymlos, their forearm bone density can really plummet by using those drugs. So I want to know what their forearm bone density is before they go on these drugs.
That's a good point. Okay, so Dr. McCormick said I was bragging, that's cool. And here's the forearm. This is what it looks like, and they look at it's the radius 33 when you're looking at.
That's the only thing I look at. Yeah,
and that's where I have my osteoporosis, which is interesting. Negative 2.7.
Play more tennis, Irma.
Pardon me?
Play more tennis.
Play more tennis, pickleball, right? So this is what some of the things that Dr. McCormick was talking about as far as the hip, right? This is the little trochanter. This is the little bump here.
Yeah.
Hey,
go back. I want to look at the neck. Yeah, it's okay. Okay, go ahead.
Spine.
Yeah, the things I look at are making sure that L1 is L1 and looking at the lines that demarcate each region of interest and making sure it goes right through the discs, exactly through the center of the discs, kind of looking at the outline of each vertebra, making sure that the machine did it properly. And then, like I said, sometimes people have pretty bad degenerative joint disease, and then one technician will change those lines around a vertebra, and the next technician won't do that. They will just leave the machine do it, and sometimes the machines are wrong. So
the the problem. The point of me sharing this is that when I was first diagnosed with osteopenia, when I was 50, I was told I had to be on Fosmex because I was going to be crippled. So that was 20, 21 years ago. So the point is that if the DEXA is wrong, or the technician or the doctor says, no, this is what it is, that was a long time ago. And everybody seemed to be getting Fosmex at that point. Women were on it far too long. Times have changed, medication has changed. But if I listened to the doctor, I probably would have been sort of a long hauler on Fosmex. And that has all of its complications. Anyway, I chose not to do that and to try to do whatever I could on my own.
You can't, people can do a lot on their own, or, if they take the right steps. And it's not just that Irma shouldn't have been put on Fosmex. That's true. I totally agree with that. But a lot of patients are told to do Fosmex when in truth they should have done an anabolic instead, because their bone density is so poor that Fosmex isn't good enough. So everything has to be looked at and weighed, and starting off, you have to do the bone density properly.
Yeah. And then the anabolics then have its own insurance problem. So a couple of layers. It's a project. It's a project that takes support on many different levels. So I think that that's one of the things that's an important takeaway. When you have someone like Dr. McCormick, who's well-versed, has had his own struggles. For those that don't know, he had severe osteoporosis. Severe osteoporosis because you were fracturing, right, in your 40s, and then went on medication for 2 years. You started with Forteo?
Forteo and 6 months of Fosmex.
And now you still have osteoporosis. Is it okay to say that? Yeah. And but you're running and you're doing your marathoning and you're doing your Ironmanning.
You're 3.3, so a lot big difference.
So I'm just looking at these questions. I'm not seeing question. Okay. My sister was recently diagnosed with osteoporosis, negative 2.8. How can we know if this is even accurate?
Good question. Start off with looking at the printout, and you look at the regions of interest. You look at, you just try to look at the numbers and see if they jive. I guess that's her first bone density. So it's very difficult to tell on just the first bone density. That's why sequential densities, you need to look at the pictures and all the numbers and, compare them. But the more bone densities that we have, the more chance of finding errors and making sure that, what we're seeing is real. So, or just knowing that it's an error. But just having one bone density, it's kind of the same as having just one C-telopeptide, just one bone marker, resorption marker. That's not good enough. You got to do two or three of them to know if they're correct or not. The more dots in the line, the more chance do we know that we've done things correctly.
So the consistency of where you get your DEXA done with the same machine, same serial number is key. But then we throw in the other kinker, which is getting the trabecular bone score. And since some facilities don't have it, do you change facilities to get the trabecular bone score? And that sort of depends, right? It depends on the severity of the DEXA.
Yes, that totally depends. People often ask me, should I change and get a TBS? I go, no, I don't think you need that. We don't need that. Because there's good and there's bad with getting a TBS. The good is we're getting the TBS. We're looking at one aspect of bone quality. The bad is we've just gotten rid of the consistency of our bone density machines. So now we don't really know, even though the new bone density has a TBS, we don't know if they did it correctly or not. But we don't know if it's as good a facility as the old facility. Just because they had TBS doesn't mean they're better trained, So if we have 3 bone densities consistently from one hospital, and it looks like every single time they did it correctly, and it looks like there's a, you know, a slow progression loss or gain, whatever we're looking at. Then all of a sudden we change to a new bone density with TBS, and it's totally different than the other three. Well, something's going on, and now we're all confused. So sometimes it can muddy the waters instead of improve things. But that said, if a person's right on the borderline of us trying to decide whether an anabolic or an anti-resorptive is better, the TBS can be the thing that helps weigh that decision, make that decision better.
Now, you can have Dr. McCormick read your DEXAs, or other certified densitometrists who are trained just to read DEXA reports is also another option. And that's something that's worthwhile if you're especially at that point where your doctor is saying you need medication, but you want to make sure that the tests are accurate to determine that you need to go on medication, right? And then Doreen is asking, would too many errors result too poor? Would too many errors make results too poor to make decisions about treatment?
Definitely. Yes.
We did have a sneak-in question on strontium. Do you want to just speak quickly about strontium?
It's just going to make, everybody on strontium is going to improve their bone density. So, but that doesn't mean they're going to decrease their fracture risk. It just means that their bones are appearing more dense. They're not really more dense, but they're appearing more dense. They might be a little bit more dense, but they're appearing much more dense than they really are.
But we don't know the quality of the bone.
We don't know the quality of the bone. And we don't know how much of that improvement in bone density is from the artifact of the strontium atom being twice as dense as the calcium atom, or, we just don't know how much is real or not.
What would you do if the hospital changes models? Can't do anything about that.
Can't do anything about that. Just know it, just understand it, and take that into account.
Just always get the printout. How should I lie on the table next time? My upper back is arched because of fractures in T6, 7, 8. Do I need to ask them to put my feet on the block?
Yes, if they can. It has to be consistent. But yeah, don't worry about some people have so many fractures in the thoracic spine that they really need a pillow for their head, and that's okay. That's not going to change anything, but they still need to have their feet on the block.
What does it mean if on the hip where the triangle line is the right side, on the right side of the picture? Does that make sense, that question?
Yeah, just the global, that's okay. That's just sometimes global hips are made that way, and I'm not sure why that is. Different companies, but yeah, that's okay.
And what can we learn about the trabecular bone score? I think we answered that, which is the quality of the bone.
And that's only one aspect of quality, though. That's what people don't realize too, is it's only the connectivity of the trabecula. That's all the TBS is telling us. It's not telling us about the quality of that crystal formation. It's not telling you about how the size of the crystal. So it's just the connectivity of the trabecula.
That was interesting. How often should we have a DEXA?
The more often, the better. So, insurance pays every 2 years usually, but if you're being treated, then you should do it every year.
Treated with a bisphosphonate or treated with an anabolic, or either?
Yeah.
Okay.
Or if there's a change in treatment, or there's a beginning of treatment. Like, let's say you had a bone density in January of this year, but tomorrow next week you're going to start an anabolic. Then I would get another bone density before you start that anabolic, even though, what's this? This is, what month is this? This is September. So if you had one in January, you would still get another bone density now if you're going to start an anabolic tomorrow, because you want to have, there's been a whole 9 months between January and and now. So ideally, you should get a bone density now.
So Chris,
Why is that? Because let's say you had a bone density okay, let's do a year ago. So you had a bone density last September. And you're going to start an anabolic now. And your doctor says, no need to do bone density, right? You had one a year ago. That's not true, because all during that year, you've probably been losing bone. So now let's say a year ago, your bone density was a negative 3.0. Now, a year later, your bone density is a negative 3.3, negative 3.4. It's worse. You start an anabolic today. Next year, a year from now, you do another anabolic, and it comes back a negative 3.0. It looks like you didn't improve at all, because a year ago, you had a negative 3.0. But now, if you would have had a bone density today, it would have showed a negative 3.4, because you lost bone density that whole time. But now, because you didn't have a good baseline done, a year from now, after a year being on the anabolic, you've improved, but it still just says a negative 3.0, because we don't know that, it was a negative 3.4 when you started. So get a bone density before you start any new therapy.
right. And that's one of the reasons why we want to do the bone markers in between or during the course of medication. So if A, it's working, or even before.
That's right. Same reason. Yes, I agree. Got to get those bone turnover markers baseline, and then 3 months after you start a treatment, a drug treatment.
So Tracy, okay, she thanks you very much. Great information. Okay, so we have to bring the call to a close, but before we do, if you can write in the chat one thing that was a takeaway for you, one thing that you learned, and it could be just to get the printout. It could be that you have to lie on the table correctly. Some very simple steps are so important just to have that little piece of knowledge. So if you could do that, that would be very helpful. And I'm going to just review, just to make sure there's nothing else. I sent my bone density to Dr. McCormick to review and consult. Very reassuring and worth the out-of-pocket cost for sure. Oh, that's lovely. Severity of the DEXA. What is the severity cutoff for going for the new facility? I don't know what that means, Krista. Krista,
Just saying it depended on severity, whether you would switch to a new facility that had the TBS. It depended on.
That's a good question, and that's hard to say, but I look at around negative 3.3, negative 3.5 as being the area. Well, yeah, in certain situations, you might want to go with the negative 3.3 and just approach it with nutrition. Maybe even negative 3.5 in some cases. Negative 3.8, I'm probably always going to say let's do a anabolic, or negative 4.0 for sure. But in those areas, if we're trying to make a decision, if the person has a negative 3.3 and they have terrible TBS, they should do a medication problem. I actually just had a patient today, exactly that. She had a negative 3.3, and I hemmed and hawed because her bone quality was right on the line of degraded. And those are hard ones to decide what to do exactly. She was a small woman, 102 pounds, 5'1", so she looks a little bit worse than she is. There's lots of things that go into these decisions. So many things.
We didn't.
It was more the decision on going to a different facility that could have offered the TBX, and then you end up switching your DEXA series.
Right. Yeah.
Yeah.
We didn't have a chance to go into the whole idea about Kristen and how if you could talk about that quickly, because that was I believe, the doctor didn't want to get an x-ray. You wanted to get an x-ray, right? She came in when she had pain. Are we familiar with that? Yeah. And then you looked at the x-ray. The radiologist looked at the x-ray and said, no, you didn't have a fracture. You looked at the x-ray and you said, you definitely had a fracture. Can you just say that quickly?
Just because well, number one, a lot of medical doctors don't have the training that a chiropractor has as far as reading X-rays. We are really good at reading X-rays, I think. I think back of my schooling at National College of Chiropractic and how many X-rays we read. I mean, we were in the X-ray department all the time reading X-rays. We got really good at it, and MDs just don't have that training behind them. So, but also I have the luxury of touching patients, and I listen to the patient. And this, if it's the one I'm thinking of, the case I'm thinking of, she had lifted some chairs. She felt back pain. I touched her back, and it was very localized back pain. We got the X-ray. They weren't. I don't even think they were going to do an X-ray. Now I can't remember. But the X-ray clearly showed a loss of height exactly where I was touching her back, and it was just so clear to me. And then that same patient had a increase. She got better over 4 to 6 weeks, and then all of a sudden she got much worse again in the same area and another area, and that vertebra that had collapsed now collapsed even further, and which made me so mad because her MD didn't believe the first time that was that she had a fracture, and the patient was she didn't know who to believe. She didn't know to believe the chiropractor or the medical doctor, and because the MD said no fracture, I said fracture. Then she got totally worse, and it completely fractured, and then she believed me because it was fractured, but it went from a 25% fracture or probably 20% compression fracture to a 50 to 60% compression fracture.
That's amazing. Vicki, can you close your Zoom? Because it's showing on the screen here.
Me?
No. Vicki? I think I lost Vicki. So just some feedback from people, what they learned, which is pretty impressive. Getting the serial number of the machine and asking for CD of the pictures. I learned how to lie on the table correctly. Thanks. Be the CEO of your own health. Be persistent. How to look at the printout once you get it. Positioning of the feet correctly. Compression fractures should not be included in score. Check serial number of machine. It was helpful to learn that one has to be placed in the same position from year to year with each DEXA. Will do an out of pocket if needed. I get my printouts and a good review. I found the slides with pictures or with scans helpful. Okay. That's Mary Jo. Hi, Mary Jo. How to look at the pictures for mistakes and getting a new DEXA. Now, somebody mentioned about the ICS, the certified densitometrist. Let me just see if I could go back to that one. I know I'm violating the time here. I heard it's important that the technician be ISCD certified, International Society of Clinical Densitometry.
Yeah, I think they should be. I think maybe there's other governing bodies. I'm not sure about that, but like I've taken the ICD twice, and it's a great weekend seminar, and every technician should be certified under that.
The technician of the facility I'm scheduled weren't certified, and this is what we run into. So, I think.
So, where do they get their training? I don't know.
Yeah.
That's a good question. I don't know.
Some facilities have mammograms, and on the side they have a DEXA, and they're not fully trained, but it's like, hey, we're here, we have this, and let's do that. And in fact, I'm working with a facility now and asking them if they do have a certified densitometrist on staff, but I asked them to get a TBS, and they're, I'm still working on that, but they have many, many facilities in New Jersey. It's a breast cancer center, or a breast imaging center, not cancer, excuse me. So lots and lots of comments here. Thank you, Dr. McCormick. That was cool.
My pleasure.
All right, so I'm going to say goodbye for now. Look, we have vlogs.
Thank you, everybody, for joining, and hope you got something out of it. So, bye-bye.
Thank you.
Thank you. Thank you.